about a little bit again, as we have done last week, about the subaortic area anatomy. A little bit of a classification of the left ventricular upper tract obstruction and types. And then I tried to concentrate mainly on the subaortic membrane with the types of membrane, the surgical indication, a little bit of actually of the etiology of the disease, and then some technical challenges that we encounter, especially with the recurrences and some long-term results. So last week we had a very nice presentation about the anatomy of the subaortic area. It's a very complex area of the heart. It's very busy. There are a lot of structures. Some of them are really very important, and we need, I ought to just review a little bit this area now, thinking about what we're going to talk about, left ventricular tract obstruction. So when I think about the aortic root really, it's all that area that goes from the sinotubular junction down into the ventricle with the interventricular septum and then the anterior leaflet of the mitral valve. So everything that is included in that area, it's paramount. There are obviously the aortic valve leaflets, with the left leaflet, the non-coronary leaflet, and the right leaflet, or sinus of Valsalva. Now, the area between the right coronary, the right sinus of Valsalva and the non-coronary Valsalva, in this area here is where the membranous septum is and where the conduction tissue comes in. After that, there is the fibrous trigons of the anterior leaflet of the mitral valve that runs just below the non-coronary sinus and the left coronary sinus, reaching on the other side, while hanging the anterior leaflets of the mitral valve. And obviously the part that you don't see here much is the interventricular septum, which is not a straight structure, but is a curved structures, because actually fills the gap from the left coronary sinus to the right coronary sinus. So this is actually a very nice drawing, and I have to say that Bob Anderson did in the 80s a lot of studies about this area, which is not only very busy, as you can see all the structures that we have talked about before, but it's also a very delicate structure. So you can see in this cut, this is the interventricular septum, this is the attachment of the root, and that is the sinus of Valsalva, and that is the cusp tissue. So this area, you can actually see that it's very delicate. And the reason that it's very delicate is because it is made up of aortic wall that has to join the ventricle. So there is a part of aortic wall, especially in this triangle that is called the interleaflet triangles, which is aortic wall exposed to ventricular pressure, as well as there are little area of muscle that overlaps the cusp. So from the inside the cusp, you can actually see that there is some muscle growing into that area. So if we now start to think about a membrane that might start to grow in this area, you can actually see that it can find a lot of structures to attach itself and to create troubles to very delicate structures. Just a reminder also that in normal heart, the aortic root is wedged between the mitral valve on the left and the tricuspid valve on the right. And that how actually creates the aortomitral curtain on this area. We will see a little bit better later on, but also with the tricuspid valve, there are some relationship with the tricuspid valve, and you can actually see the tricuspid and the mitral are separated by tissue. Whereas in complete VSD heart, that is not not the case, because this area it's all comprised by a common ring, and the aortic root is displaced anteriorly, upsetting the geometry of the left ventricle outflow tract. Now, I'm not gonna talk a lot about this. I'm going to touch again later on when we're going to look actually into the geometry of the left ventricle tract and the root, but it's just something actually to keep in mind because it's an important feature. So for what pertains the classification of aortic valve stenosis, I think we can divide them into primary obstructions like subaortic membranes and left ventricle tract tunnels, and secondary obstructions like complete VSD with a gooseneck deformity, accessory mitral valve chordae, and also the presence of mitral valve prosthesis. So the definition of a membrane in the subaortic area is a fibrous membrane that's creating an obstruction in the left ventricle tract. It's present in 6% of children with congenital heart disease and is responsible for 20% of the obstructions in the left ventricle tract requiring some form of intervention. Is characterized by rapid progression, hence the patients that we see with problems start around 4 or 5 years old into the early teenagers, but most of the patients about 9, 10 years old. Obviously, it creates a pressure gradient within the left ventricle tract, with the left ventricle at very high pressure and the area above the membrane at a lower pressure. It can be a complete ring, like the one depicted there in the picture, or an incomplete ring, and also can be found at variable distance from the aortic valve. Looking at this histology, it's very interesting to notice actually that that is comprised of few layers. So again, actually, it's a very nice preparation. It's a very nice cut. So you can see here the membrane where there are those black arrows, and that is the area that goes up into the sinus of valsalva. And when they in this nice preparation, they stain the collagen in blue and the elastic fiber in black. So you can actually see that the layers are mainly constituted by collagen, and there are very few elastic fibers. But not only that, is the fact actually that there is also a subendocardial fibrosis. Usually this area is much smaller. This is the subendocardial layer, should be much thinner than that. But not only that, but also invades the collagen, invades the early muscle layers, and that is very important to notice that, because collagen, we know it hasn't got elastic properties, and that creates a very stiff subendocardial layers of the myocardium, which give actually reason to some of the technical surgical correction that we need to put in place during surgery. The etiology or the etiology is not completely clear. There is a rare autosomal recessive inheritance, but the etiological mechanism of creation of this formation of this membrane is mainly a mechanobiological property of the left ventricular tract mixed with the fluid dynamics. In fact, actually, it's been now seen that some left ventricle morphological abnormalities, especially the coupling between the left ventricle outflow tract and the aortic root insertion, can produce derangement and mechanical stress in that area, which then stimulate a fibrotic cellular response, which then leads to the deposition of collagen and the formation of the membrane. So this concept actually comes from this theory comes from the concept that there is an aortoseptal angle, which is formed by the long axis of the ascending aorta and the plane of the interventricular septum, creating an angle that is more than 90 degrees. has been studied very well by the group in Boston. I found this very interesting paper from Pedro del Nido in Boston, where they looked actually at that area and have a look actually how the change in the anteroseptal angle can influence the shear stress in that area. Not only that, but they also look at the presence and the location of ventricular septal defect and the shunt velocity through the VSD. So their results actually shows that variation in the aortic septal angle produced a marked elevation in septal shear stress. So for an angle of 150 degrees, the shear stress measured was 103 dynes for centimeter square. Well, actually, if the angle actually closes to 120, and that is a baseline physiological conditions, the shear stress can be valued up to 150 dynes per centimeter square. And also the presence of a VSD enhance the effect with an increase in septal shear stress for VSDs that are closer to the aortic valve. So this is another way to represent it actually. So this is a 150 degree angle, which is supposed to be a normal heart. Well, actually, when the angle closes so that there is a steeper angle, you can actually see that the septal shear stress goes up. And that is also, it's also true from where the membrane actually get its place. So it's got the maximum shear stress for a distance from the apex of around 4 centimeters. Now, looking actually at the presence of a VSD, for a septal shear stress of 150 dynes per centimeter square, the presence of a VSD close to the aortic valve increases the septal shear stress to up to 250 dynes per centimeter square. So the conclusion of this paper was that small changes in the orthoseptal angle produce important changes in the septal shear stress, and this supports the hypothesis that stress-stimulated growth factors and cellular proliferation can be a risk factor for development of the subaortic stenosis as a deposition of collagen. So having seen actually how this membrane is formed and what are actually the problem with the geometry of the left ventricle to aorta, have a look actually indication for surgical intervention, which are not that dissimilar from the indication for any aortic stenosis. So the first are symptoms. In young children, symptoms are more difficult to pick up, but mainly are the same symptoms of chest pain, shortness of breath, fatigue, and low exercise tolerance. And in the most difficult cases or advanced cases, also collapse. A gradient of more than 30 mean gradient of more than 30 millimeters of mercury, it's an indication for surgery, as well as the presence of aortic regurgitation. So I'm afraid for the non-surgeons now, I will have to touch actually on how we surgeons put our eyes actually on the images and trying to figure out before the operation how we are going to approach this condition. So there are three main types of aortic subaortic membrane. The one that is in panel A, that is distant from the aortic valve, so it doesn't touch the aortic valve, it doesn't involve the mitral valve. It can actually be at any area below the aortic valve. Here is represented quite close, but in reality, in these cases, we can see actually that it's farther down. Then in panel B, you can actually see the one that are very close and attached to the origin of the cusp, as we've seen before, and invading actually the cusp, creating a tethering of some of the aortic valve leaflets, and also in some cases, like depicted here, invading both sides, both the ventricular and the aortic side of the leaflets. The most difficult one actually is obviously the one that not only it's attached to the aortic valve, but also invades part of the anterior leaflets of the mitral valve. Now, this area, as I depicted before, actually, it's a very complex area. And in particular, the presence of the trigon, the fibrous trigon, doesn't make this understanding and clearing the plane between the membrane and the anterior leaflet of the mitral valve very clear, because the trigon itself is a stiff and rigid area that can be mistaken for the invasion of the membrane into the mitral leaflet. So these are actually some images. The images that I found, I think actually every my colleague actually found useful, is a paraexternal long axis view. Obviously, this is a transesophageal echo, so it's a reproduction of that. But you can actually see that the membrane in this case, it's far from the aortic valve. And the important thing, actually, the aortic valve closes, making the praying hands position. And so it's a membrane that is far from the aortic valve, is not invading the aortic valve, and is not present also on the mitral valve leaflet. So you can actually think, looking at this echo, even though it's just a still image, that it's an incomplete subaortic membrane far away from the aortic valve. This is another actually example of this, the panel on the right. There is a subaortic membrane which is far from the aortic valve. You see the leaflet here are closing well, and the anterior leaflet of the mitral valve, it's clear because it doesn't show brightness into it. Now, in this other case, actually, the aortic valve leaflet, you can actually see the subaortic membrane is really attached to the leaflet. You see actually that the leaflet, one leaflet is opening and the other one it's held in a semi-closed position. So you can actually imagine that this valve is not going to work well even after the removal of the membrane. And you can actually see that there is some flaring here on the aortic side of the leaflet, and that actually have to make you think actually that the membrane is invading up into that area. So this patient will probably require also an extensive aortic valve repair. In these cases, despite the fact that the membrane it's far away from the aortic valve and the aortic valve leaflet seems to be closing well, you can actually see that it's a complete membrane, because it gets to attach onto the anterior leaflet of the mitral valve with this bright area on echo. CT as well is used to show the presence of the membrane. It shows quite well, and here you can actually see a complete membrane that attaches onto the subaortic septum, but also on the opposite side on the anterior leaflet of the mitral valve. This image is quite blurry. I'm really sorry for that. But what I wanted to was more interested actually into the intraoperative findings. So you can actually see that in this image it looks like a slit-like presence of a membrane underneath the aortic valve, and that is what it is. And restricts actually the subaortic area quite a lot. It's tethering also the left coronary cusp and the right coronary cusp too, and it's quite a firm. You can actually see the type of membrane, how it is firm, is not elastic, and it's all full of collagen. Now, just actually another touch about the complete AVSD's hearts, and having spoken about the aortoseptal angle, you can actually see how this will impact a lot in subaortic stenosis in complete AVSDs, in giving the so-called gooseneck deformity of the left ventricular outflow tract. And these are actually some examples of membrane present in complete AVSD. repaired complete VSDs, and how the membrane can actually can be attached to also the repaired left AV valve. Okay, now we're going actually into some surgical consideration, and also with some personal tips and tricks that I've learned through the years dealing with this condition. The operation is conducted via medial sternotomy, and I tend not to limit the incision, especially at the top, because the best view is really from the top down into the root. The cardiopulmonary bypass is usually a single right atrial cannula, and the aortic cannula is positioned as distal as possible to allow a comfortable aortotomy. I personally position a left ventricle vent through the right upper pulmonary vein, inserted through the right upper pulmonary vein across the mitral valve, and that's actually to give a very nice and bloodless field while working down into the into a funnel. Before going on bypass, I tend to dissect and develop the plane down into the root in correspondence of the non-coronary sinus and the left atrial roof, in order to create a nice area where I can look at my incision later on. I tend to identify the right coronary artery origin, and remember actually that in particular, if this is associated with bicuspid aortic valve, the right coronary artery can be displaced superiorly, making actually your aortotomy the plan for your aortotomy has to be very careful. I use blood cardiplegia because it's been shown that for hypertrophied myocardium, it's better cold blood cardiplegia, and in this case I also use topical cooling with ice lash for the same reason, to maintain the hypertrophied myocardium at a cold temperature. I then perform a comfortable aortotomy, and as I was alluding before, extending into the mid portion of the non-coronary sinus. I put retraction sutures and also gentle AV valve leaflet retraction, either with a leaflet retraction or sometimes also with some pledged sutures passed into the belly of the aortic valve leaflets to retract them away from the operative field. And then there is an inspection of the subaortic area. This is just drawings of how the operation is performed. So a comfortable transverse or OK stick incision in the aortic valve, making sure you have enough space to suture comfortably back the aorta, taking care of the right coronary artery, and then you just actually start to identify the membrane. I found actually that especially in the first time membrane that are not attached to the aortic valve, quite invariably I try to pull it in few areas and the membrane start to peel off itself, and using as so-called a blunt and sharp dissection, you try to remove the circumferential membrane, taking really care of the area of the membrane of septum, and trying to respect that area as much as possible. These are other drawings about how to excise the subaortic membrane. In this case, in panel A, it comes off quite easily because it's not attached to any other structures, but sometimes you need to do a commissure release because the membrane can tether the leaflets in that area, in the interleaflet triangles, and then also you can very gently remove some of the tissue from the aortic side of the aortic valve leaflets. So this is actually a view down into the subaortic area And in this case, actually, the retraction is done via a skin hook, which I sometimes use because it hooks very nice. You can use a stitch as well. This is for most of the surgeons, our juniors. You can use a stitch actually in this area so that you can get hold of the membrane, and then you just start to peel it off and to remove it in order to clear out the left ventricle tract, and that is actually how a complete membrane has been completely removed. Now, one part of the operation that I personally regard important is the performing a myectomy. Now, we've seen actually in the histology how the collagen invades the endocardiac layers of the muscle, and I regard that actually an important part of the operation. Now, the myectomy, it's started in the mid of the of the right coronary cusp, and then progressed actually towards the left coronary cusp. And for me, it's important in case the preoperative echo shows that this area it's bulging out quite a lot, to remove that area, but also to create a break into the subendocardial layers that can tether the left ventricular tract. So I tend actually, like depicted here, to do it more lengthwise than in depth. And then with, again, actually the aid either of a blade or scissors, you just create a break into the muscle layer, which are usually quite fibrotic. So once you have achieved what you want, you size the left ventricular tract with a predicted Eiger dilator. One very important suggestion is not to attempt stretching of that area with an Eiger dilator. It's not an area that you can stretch in order to achieve better results. The results is achieved by removing the membrane and by freeing up that area and to make it more elastic. So don't stretch that area with an Eiger. I then proceed with a warm washout to possible debris from the left ventricle, close the aortotomy in 2 layers, and then adhering. And I tended to allow 15 minutes of reperfusion of the hypertrophic myocardium before aptepning and coming off bypass. Now, two aspects actually that not two aspects, sorry, 2 ways you can then identify if your resection is been successful once off cardiopulmonary bypass is to measure the gradient. You can use it a transesophageal echo, but I have seen that it tends to underestimate, and finding the perfect angle to see the left ventricle tract velocity can be challenging, but a velocity of around 2.2 to 2.3 should be enough. I personally have learned to measure directly the left ventricle with a needle, and I measure it with a needle actually, and then find the gradient, or you have to find the gradient that is less than 30 millimeters of mercury. If you still have a residual gradient, you have to do more work. You cannot leave a gradient more than 30 millimeters of mercury. So I'm afraid you have to go back and do more resection and trying to enlarge more the subaortic area, adding an extensive myectomy. Now, the recurrence is associated, in fact, with the immediate postoperative gradient across the left ventricular tract of more than 30 millimeters of mercury. And when that is the case, the recurrence of a significant gradient is much earlier, at approximately about 4 years of age. So I'm now to review a little bit of the literature about results of membrane resection. And this is a paper from the Brompton retrospective review in 50 patients from 2000 to 2005, and they compare data from patients who had redo surgery during the same period. So they had 35 patients had a primary operation and 15 patients had a redo surgery. The follow-up was 2.5 years. And of the 15 redo patients, only one patient had at the previous operation a myectomy, and 14 had an isolated resection. And 4 patients of the redo patients had an immediate gradient of more than 30 millimeters of mercury at first operation. So that actually gives the idea of the importance of the myectomy and measuring the gradient in order to leave theater with an optimal result. Another paper actually from an international group that put together their experience, collected 46 patients in which 19 had a membrane resection plus a sectal myectomy and 27 had only a membrane resection. Now, the preoperative subaortic gradient was slightly more, 103 millimeters of mercury plus minus 40 in the group of patients who had membrane resection plus aggressive myectomy, versus 75 millimeters of mercury for the group of patients who had only the membrane resection. Now, Now, the postoperative gradient, it's quite important because the patient who had only the membrane resection had a significant higher postoperative gradient than the one who had the membrane resection plus the septal myectomy. They had actually 9 patients that out of 27 who had only the membrane resection who underwent redo surgery, and because of significant regrowth. 7 had a reoperation and they added a myectomy this time, while actually the 19 patient who had membrane resection plus septal myectomy, none of them had a detectable membrane at follow-up. This is actually a nice graph actually of basically linking together the left ventricle outflow tract gradient at the last follow-up with the left ventricle outflow tract gradient before surgery. So the green triangles are patients who had the membrane resection plus aggressive septal myectomy, while the blue had only the membrane resection alone. So the thing actually that comes to my eyes immediately, actually, the variability of a relationship. So there are patients who had quite a high gradient before and after, and well, actually the green triangles actually show that they had actually a more achievable and constant relationship between the two, showing actually that adding a membrane resection might give you well, not might, but gives you a better constant good results in this operation. Now, looking actually at this large paper from large group from Melbourne, just 4 years ago, they evaluated over a long period of time from 1989 to 2015. They evaluated 72 patients, but they follow them up for a longer period, which is why it's quite important. So the results of surgery were very good because they had 0 in-hospital death and they had 3 late deaths. So for what concern the late death, actually, you can actually see that once the time of the redo surgery probably has passed, then there is a constant a nice long-term results. But the most depressing is actually the time of the recurrence. As I was saying, around 5 to 10 years actually is where most of the recurrence happens, and there is factors for recurrence in 20 of the 76 patients. It's an immediate residual gradient of more than 15 millimeters of mercury, so they put the bar really very low for that. and a membrane also adherent to the AV valve. It's a risk factor for recurrence. The risk factor for reoperation in 13 patients out of the 69 that were followed up were initial age at surgery less than 5 years, and again the membrane adherent to the aortic valve. So these are actually the take-home messages of this presentation. That it's a wide spectrum of disease, from isolated incomplete membrane to complete membrane attached to the aortic valve and the mitral valve, that can give troubles in the future. The early mortality, we know it's very low, as well as the early morbidity. And in reality, looking at the series, also the complication rate is quite low. The risk factor of recurrence is early age of first operation, so that is an important to stratify our patient, as well as aortic valve involvement. Immediate residual gradient also of 15 to 30 millimeters of mercury seems to be an important risk factor. The aortic valve involvement, in reality, for me, reading and reviewing this topic, it is a surrogate for an aggressive disease, and it is also in the presence of a VSD. Can actually accelerate the progression and the recurrence of the disease. And the other thing actually that I think we ought to tell our patients is that long-term results are affected by the reoperation rate, with a up to 60% reoperation rate at 12 years, which seems to be more than what we see. But I think actually that following up these patients for long term, it's very important. And the other thing actually that I just want to say to our juniors, actually, that redo surgery in these cases can be challenging, and that is when actually you have to take actually some in order to avoid the third redo, you need to take some actually difficult decision in theater and be more aggressive, and consider also maybe employing other type of repairs, which I'm not actually describing here because are more pertaining to the left ventricle tunnel. But especially when there is a narrow and long infundibulum on the left ventricle tract, I think actually we need to consider those. And I stop here, and I'm taking questions if there are any. Thank you.
I don't have questions, but I have to appreciate the lecture. It was wonderfully rendered. The depictions were lovely. The explanations were extraordinary, and the correlation between what we see on echo and what we see actually in theater, and the tips that you gave at the end were a treasure. So thank you very much for the lovely session.
You're welcome.
And I think when you said about the other procedures, you were talking about sort of cono, and I know that's a different direction altogether. But would you still, so I do have a question. So would you still think that we go in for a second time, like a redo resection or a myectomy, and then the third attempt would be at a cono, or would you think the second time when we go in, we should think of like a subvalvular enlargement with the patch?
Yeah, it's a good question actually, because I've sort of the last 10 years of my practice giving the benefit of the doubt at the first redo, especially if the patient presented early, and especially if the first membrane was not that close to the aortic valve. I think actually that I sort of have the feeling of let's go back and clear that area again, maybe do a more extensive myectomy. Depends actually if myectomy was performed the first operation,
Right.
and how aggressive was that. And so it is I think actually that the first reoperation, actually, you should give the benefit of the doubt and go back actually and trying to clear out. Now, once you go back in, you will see that that area, it becomes very, very difficult to deal with, because when the membrane grows back, it's not like the first time membrane. It's much more actually of a generalized collagen deposition in the whole area. And even if actually the myectomy was performed, sometimes it's difficult to see that it was performed, because first, because actually the muscle grows back because of the LV gradient, and second, actually, because I think the shear stress produces a generalized deposition of collagen in the whole area. And most of the time, in the redos, it involves the mitral, it involves the mitrals as well, quite a lot. So I think actually that, as I said, I made my mind that, you know, I give the benefit of the doubt, and I think actually that is what we do at All the Hay, trying to clear up that area again. But if then it comes back again, I think actually that a more radical operation has to be thought actually. And here we're talking about, you know, modified cono, more than a cono itself. Is the aortic valve? It's good. Yeah.
Thank you very much.
I think Salam was next from a question.
Hi, yeah, thank you very much. Very nice presentation, Attilio. Well done, well prepared. I have a bit of comment and question at the same time. So there are some studies here and there, especially abroad, putting another quite different classification for the subaortic stenosis, and they put like discrete and tunnel-like. And for the discrete, they subclassify into two types, the membranous or the diaphragm-like, and the second one is the fibromuscular ridge. And the rationale behind that classification, they are putting something for the invasive cardiologists. So they are saying that for the membranous or for the diaphragm-like, there is a space, there is a place for the balloon tearing or balloon dilatation for that diaphragm, rather than the ridge, rather than the fibromuscular ridge. And Suarez de Lezo has published in the Circulation, the American journal, his 25-year study of balloon tearing of the diaphragm-like membranes. 76 patients, 16 years follow-up with 77% success rate, very good long-term results. Any comments, Attilio? Any experience? Anything about that kind of modality?
Yeah, basically, if I think actually that if you catch it very early, and I haven't got under my eyes actually that paper, but you know, we tend I think actually as a country, because having worked in a few places, I think actually that is to reach actually a certain degree of gradient before submitting the patient for surgery. That means actually when you have a velocity of about 4.5 or 5 meters per second, you know, I doubt that you're going to be able to stretch that area of that membrane, only because when I go and have a look actually at the composition of that membrane, I struggle to believe that there is a balloon that can stretch that, because even my knife sometimes, or the scissors sometimes, struggle to go through that area. So, you know, it is something that I suspect can be done at the early age. I don't think actually that our interventionists have got experience on that, but it will be interesting to see what they think about that.
Okay, thank you.
Sorry, Attilio, I mean, I've not heard or seen this. I don't have any experience either.
Yeah, I've never heard that. You know, maybe it's just, you know, sometimes you know, there are individual cases and individual experience, like we have experience in ballooning aortic coarctations, which is a unique experience, and in some hands can work because the indication can be very restrictive for that subgroup of patients. That doesn't mean actually that you have to treat all the coarctation with ballooning. The same thing I suspect it's here. So if you take out a subgroup of patients that have a mild disease and maybe not very bright membrane, you know, maybe ballooning that area breaks the circle, and it might spare the operation.
Okay, thank you.
Abhishek and Ansh, you want a question?
Yeah. So thank you, sir. This is Abhishek this side. It was a nice, lovely presentation. We learned a lot. I have two things to ask, sir. One is that when you're using the knife for the subaortic membrane resection, do you prefer 11 or the stab knife or a 15 knife? This is my personal question. And the other thing is that there was recently a case of it was a redo post AV septal defect repair. There was a subaortic membrane resection where we really struggled to distinguish between the mitral tissue or the AV valve tissue and the membrane. So is there any specific tip which you want to give us which will help us to identify the tissues in that area to separate where we can start the resection from?
Yeah, it's a very good question. The second one, the one with the knife actually is personal preference. I tend for the first time round not to use knives, but just a Watson chain and a skin hook, and try to peel it off and cut with the scissors the little strands that might keep the membrane attached. For redos of membrane, actually, yeah, the knife can be used, and I tend to use like the one that has been shown into the pictures, the pink knife, so a very diamond knife, very sharp and small. Also, just for the juniors, actually remember that every time you enter with a knife into the aortic area, you can damage the leaflet. So remember actually really to manage your assistant in a very very careful way, because that is when problem starts, if you accidentally make a hole in one of the leaflets. The second question, that's difficult actually, Abhishek, because, you know, as I said before, the aortic, the arterial leaflet of the mitral valve in that area, it's already fibrotic because of the presence of the trigon. And then if on top you have the membrane adherent, and you can see actually that area it's not enlarging, then you know you're a little bit in trouble, you see, because, you know, you can't enlarge that area. The trigon will not allow you to enlarge that area, so you need to shave it off as much as you can, and you need actually to continue trying to shave it and give a little bit more space. One thing actually that I find useful sometimes is just to make some vertical cuts into the septum, so that to create a little bit more of a springy left ventricular flow tract.
Thank you, sir. Thank you for this. And the one, you have given us a lot of tips, like in the slides, like the surgical techniques. One beautiful tip which you keep on giving us on the table is that whenever we are doing an extensive aortotomy, to take the corner stitches and keep it steady so that the aortotomy does not extend because of our extensive dissect of our pulling. Thank you, sir.
Yeah.
Thank you.
Yeah.
Ansh?
Yeah. Good morning, Mr. Lotto. Good morning, everyone.
Hi. Hi, Ganj.
It was absolutely wonderful, Mr. Lotto. Thank you for that. I'm sorry I joined a bit late, but I just wanted to ask, I don't know, a tricky method which I picked up in India, where I was working with my last boss. He always used to enlarge the restrictive VSD at the posterior inferior border whenever it was associated with the SAM. So while excising the SAM, he always used to enlarge this restrictive perimembranous VSD at the posterior inferior border. Is it a good practice, or we shouldn't be doing it?
I don't know if he's familiar with that. I'm not familiar with that technique, but, you know, from the aortic root looking down and enlarging the VSD, I think actually you're risking the conduction tissue. So you really need to be very, very careful in doing that. unless you do it from the right atrium. But then, you know, it's a different operation actually. If you have a VSD plus a left ventricle obstruction, you know, usually the patient is small, and it's a more complex operation.
All right, boss. Thank you very much. Thank you.
Thank you.
Yeah, and unshipped was a primary operation where you're dealing with a restrictive VSD, and then you know that there is a potential for subaortic resection. And sometimes you do see some fibrous tissue as well. You can reach out through the VSD and resect it, as long as you're careful you don't damage the bundle. But anyway, Attilio, I think it's a truly exceptional lecture. It's a truly a professorial lecture, and it's very
Yeah, too good.
no, it's very nice that the way you presented, the way you prepared, the time you spent to do that is really you set an example for everybody.
Thank
So
you.
it's very nice. So I'm sure you might have come across with literature, or you might have gone through. Can you just tell us about the incidence of complete heart block, which people worry about, especially in the redo operations?
Yeah. On the that was I was trying to allude actually. I didn't want to put too much emphasis because I think actually that in reality the incidence of the first time operation is not that much. And
the reoperations we worry about, isn't it?
Yeah, I didn't want to put emphasis because in reality, as I said, you know, it's not much. So, but in redo part, that is the area where you have to be a little bit more careful. Now, there aren't actually many data about incidence of permanent heart block in the redo subaortic membrane. But I had a look actually. I think in the Melbourne was still, you know, very low actually, you know, so it's something that we need to be aware. But I think because we are all aware of that area, is not that high, so it's not prohibitive high. Obviously it goes higher if you start actually to be aggressive with modified cono and so on, but that is a different operation. So I think actually that for redo membranes, we are all as surgeons aware of that corner, and I think that we all respect it, and that is probably not where the main problem resides in redos. So we tend actually to live there, and we are probably a little bit more aggressive on the myectomy and on the sharp dissection of the redo membrane. And also redos actually looks like actually the membrane goes much more deeper into the ventricle. So one thing that I do actually is just to follow into the septum, deep into the septum, into the ventricle, in order to remove it not only circumferentially but also longitudinally.
Thank you, Attilio.
Ramaraj?
Yeah. Attilio, thank you for very nice teaching, to the surgical aspect for us. So on the same context, but in a ABST setting, I just wanted to ask, you got vast experience in terms of them developing or as predicting the subaortic stenosis, because I had come across 3 of my patients, with the subaortic obstruction in a like a 2-year or even later presentation of LVOT, which is a known association we always look for. But the type of the obstruction, was only one patient I could say that it was involved with the AV wall repair and the tissue. The other 2 patients, they had similar like a discrete subaortic fibrostic tissue. So from the initial repair, from your surgical experience, is there any way of predicting which patient could potentially develop into different types of LVOT obstruction in AVST, post-AVST repair?
No, it's a very interesting topic actually that probably deserve a lecture on its own. When I started to do complete VSD, there was this big question mark about left ventricle obstruction after complete VSD, which I haven't seen really much. Then I started to do the Australian repair, the single patch repair. And again, actually, the main worry is actually, oh gosh, we're gonna have more subaortic obstruction, which in reality, even in the published papers from series, is not really a big problem. Now, what I think is a problem is the angle that it creates, and that the long gooseneck deformity that predispose that area to the position of collagen. Hence, I think actually that that area it's usually a little bit longer and a little bit far away from the ventricle, but I don't want to say that it's a false myth actually, but there are clearly some patients, but I think actually in the modern way of dealing with complete VSD and respecting that area, we don't see as much as I thought I would have seen when I started, 14, 15 years ago to deal with complete VSD. I'm not sure actually what is Ram or Rafael, I know you are there actually, what is your experience with subaortic stenosis in complete VSD? I tend not, my idea is that I don't see as many as I would expect it.
I think you are right, isn't it? We hardly see maybe one a year or less than that in that setting of previous AVSD. What we see subaortic resection more commonly is non-AVSD cases.
Yeah.
Yeah, thank you, Attilio. Yeah, I agree, Ram. Actually, I don't see that many, but the one or two which we have, there's one of my patients coming, also typical like a long gooseneck with any other subaortic membrane and fibrosis, what we see. So maybe it's not that, to do with the AV valve.
Yeah, no, absolutely.
Going into that mechanism.
There is an association with the accessory mitral valve chordae to the septum. That is recognized. Usually it's farther down, and it just keeps actually the ventricular tract, tethered. So I think actually that is one aspect to always look actually if there are accessory tissues, accessory chordae, but not as such actually really membrane formation in that area because of the complete VSD. It's not as much as I would have expected to see.
Sure. Thank you, Attilio. Thank you.
You're welcome.
Attilio, fantastic presentation. I mean, I echo the
Thank you, guys.
thoughts of other people in the fact that this was especially for the junior stuff, a fantastic example of how to correlate surgical findings or echo findings and put it together in a presentation without overload of information, so an appropriate amount of information and pictures and description. So thanks again for putting it together and giving us this presentation.
Thank you, guys. You are too good to me.
Take care.
Thank you.